So my name's Nixdorf, and I have the opportunity to give a presentation about something I'm passionate about, and that's the field of TMD. And I'm very lucky in that I am in a division that has some luminaries that have come before me. And thinking about this talk and where I wanted to go with it, I was going, okay, we've been doing a lot of research for a number of years and looking at where's the needle been moved. And my mindset now, looking at the research and so forth, is that probably the best next thing to move the needle now is general education to dentists, to the population, and systems aspect of things to get information out so people know what to do. So from that perspective, this is more of an educational type talk with a little bit of research put in. And with that, I'm going to get started. So as the director, I kind of think about it globally and have the missions of research, education, and patient care under that umbrella. And so I wanted to start with first defining TMD. So the title of the talk was Demystifying it. So what's kind of missing? Well, what I found is that people don't understand what TMD is. And first of all, TMD is temporomandibular disorders. It is an umbrella term for the pain and dysfunction of the jaw, the masticatory system, the muscles of mastication, and the jaw joints, the TM joint or temporomandibular joint. TMD is incredibly common. It affects 1 in 8 people. That's a huge number. One research study showed that that's 35 million people in the US alone. And as we're looking at this audience here, when you're thinking of 1 in 8, there should be a number of people in this audience that have TMD. Can anyone see their TMD? And that's one of the difficulties. It's not talked about, not heard about, not addressed so much in the public sphere, of which I'm taking this opportunity to hopefully elevate that a little bit. From that perspective, TMD is not well taught within our healthcare education. And what I mean by that is in medical school and primary care specialties, there is 0 requirement to teach TMD. Dentistry is a little better. Dentistry has a requirement. A latest survey, which was done about 10 years ago, showed that 95% of dental school self-reported that they are far from optimal in their education to dental students in TMD. So we've got a long way to go. I think our physical therapy colleagues are doing a better job. I think they are have requirements taught in 98% of their schools, and 60 to 61%, I think, is the number that said that they're doing an adequate job in educating their students. So that's a problem. That problem is that patients are seeking care with dentists and physicians, the ones that are least exposed and least knowledgeable. And therefore, it's probably no surprise then that the societal cost that's estimated in the US is $12 billion to society. I have a hard time conceptualizing that number. I get to play with numbers all the time as a faculty member. How big is 12 billion? It's big. It's really big. And so this is a problem where there's a mismatch. And as you can imagine, the patients are kind of caught in the middle. And so what do patients say about this? And so I will kind of read a preface. There was a very important publication that came out. It's this publication. It had the dubious, dubious action of being published in March 2020. And for some reason, society wasn't paying attention to the publication at that time. I think there were other important things that were going on then. But the preface for this publication, and I'll read it so I get it correct, that starts, I want to read the first paragraph. And this is from the patient's perspective. Everyday activities, including eating and talking, are often difficult for people with temporomandibular disorders, TMD. And many of them suffer from severe acute pain due to this condition. Common social activities and most people take for granted, such as smiling, laughing, kissing, can become unbearable. This dysfunction and pain and its associated suffering take a terrible toll on affected individuals, their families, their friends. Individuals with TMD often feel stigmatized and invalidated in their experiences by their family, friends, in particular, healthcare community that frequently relies on seeing a condition in order to treat it. Misjudgments and failure to understand the nature and depth of TMD can have severe consequences, more pain, more suffering from individuals, their families, and society. People with TMDs, desperate for solutions, often seek multiple clinicians, turning to dubious treatments in search of a cure, which can potentially lead to iatrogenic injury, costly yet ineffective treatments. As a clinician, an educator, and a researcher, that's a sobering statement. I've been doing this for 20 years, and it existed for 20 to 30 years before me. So that's something I think is hard to sit with, how well we have failed to really move that needle, which is hence why I wanted to start with, where is the field? Where do we need to take this going? And that's why I'm looking at it from more of a public health type perspective. So what I'm showing here is how the typical TMD patient presents. And so these are kind of the different qualities, locations, and as from the eyes of a clinician, how you would be asking questions on how they're presenting. And the topic that I want to get into is, well, how do we start engaging with the patients and interacting with them so that they better understand kind of what's going on? And so I'm going to start kind of a little bit from the perspective of pain. What is pain? Pain is basically an alarm system. It is a system that tells us, the individual that's experiencing it, that something's not right. It's alerting, it's offensive, it's to motivate you to do things. So that alarm is on. In chronic pain, that alarm is on for 3 months or longer, sometimes years. So using the analogy of a house alarm, if your house alarm is on constantly and you can't shut it off for 3 months, do you think that's going to affect you? I would think so. I wouldn't want to be living in that house. But yet patients can't escape it. And so what do? They learn to manage as best as possible. They learn to ignore it, get away from it, distract themselves. They got lives to go on to. They got work to do. They got family to take care of. They've got their life to live. So they learn to dissociate themselves from it. And so the problem with TMD is it's about how you're using your jaw. And so the difficulty then is as you disassociate, you're no longer feeling and sensing what's going on. So if you don't feel and sense, that's like in our field, if you don't measure something, you don't understand it. If you can't measure it, how do you monitor it? And so patients learn not to feel, not to sense, and that puts themselves at risk for further problems in the future. And so this type of approach ends up being problematic because it then sets them up for other problems. So case in point, say you have your elbow, you hurt your elbow. What's the first thing you do in the acute phase? You're going to guard it, right? You protect it, you don't want it to re-injure. That's what pain's kind of doing. So what does that look like in the face? You hurt your jaw, it hurts, you guard, you clench. We refer to that as co-contraction, where you're using some of your elevator muscles and, that close your jaw and some of your opening muscles that open your jaw. And when you do that, you're holding it together. That's just like with your arm, you're using both your contractor, and that's what you're calling when you're bracing. Well, that's increasing muscle activity, which is now a perpetuating factor. Now do that for months on end. If you did that for maybe a couple hours just holding a book, your arm hurts. So imagine what's going on in the jaw of our patients. So that's the co-contraction aspect of things. And remember, patients have learned not to feel. We get good at everything we practice. Practice makes permanent. Good practice makes good things permanent. But remember, patients are practicing not feeling things. So they're trying to avoid it. So they're not sensing things. And this sets up a situation where the patient, as they're going through their world, things will be getting worse, they don't sense it, and they present as a flare-up, and how they'll talk to dentists and their family as in the pain comes out of the blue. They're not aware, they don't know the antecedents that led to that flare-up because they're not measuring it, they're not sensing it. And so one of the treatments then is to try and get that mind-body connection back together, and so that patients can sense what's going on, because when you can start measuring it, you can start addressing things. Recent research at the University of Minnesota, led by Dr. Emily Kennard, was looking at outcomes. To give you a backdrop to that, outcomes in TMD are usually the majority of patients, we're talking like 80% of patients or more, are much better in 3 to 6 months. And so that's across almost all types of interventions in the TMD world. Taking the rehabilitative approach that we do at the University of Minnesota, we found within her study at 6 weeks, so that's not the 12 weeks to 3 months, we're a month and a half in, doing what we refer to as self-management only at this stage, 70% of patients are already meeting that clinically significant point of their feeling better. Within that process, when asked and patients self-reporting, 95% are saying they're satisfied or very satisfied with care. So I think that's moving the needle, one patient at a time type approach. And that's really encouraging to see. So what is this rehabilitative approach that I'm talking about? Well, what we refer to as the first step is self-care or self-management. And self-management has a few components to it. Broadly speaking, and we've broken it down into more details, but broadly speaking, you can put it into 3 components. Those 3 components are education, helping the individual that's suffering with TMD to understand what they're suffering from, why, how things work, how things don't work, and where evidence is. One of the studies coming out of the UK showed that the #1 part of education was confirming to the patient that the person diagnosing them knows what's going on. Because so many times patients feel things and their mind starts wandering into the negative aspects, like, oh my God, do I have cancer, or that aspect of things. And so being able to say, yes, I know what it is, I know how to treat it, and this can be addressed, is one of the biggest therapeutic effects associated with TMD treatment. And so from this evidence-based approach of self-care first do no harm, education is the biggest part. Another part is oral habit reduction. We did not come with a manual when you were born. At least I didn't, or I lost it. And so how do you use your jaw? When do you use your jaw? What is it using to? I'll make a case in point here. Your teeth are supposed to touch with 2 functions. Can everyone in the audience list those 2 functions? You all have jaws and teeth, so don't you know how to use them? Biting, yes. So chewing, biting, 1. You got the easy one. The hard one, swallowing, awesome. And so if you don't believe you need to put your teeth together to swallow, I challenge you to keep your teeth apart, lips apart, and swallow. Go ahead, try it. See how well that goes. And so the point is you're fixing your jaw to use your muscles in your neck to initiate swallowing. So if you're not biting or swallowing, your teeth shouldn't be touching. Whose teeth touch more often than those 2 tasks? Probably all of us. The ones that didn't raise their hand are either asleep, that's possible in my talk, or unaware, like I was talking about, because clenching actually is a normal habit. It's things that we typically do. People with TMD, their sensitivity is moved more to the left. It's a leftward shift of the sensitivity. So now these activities cause pain in these individuals where the average person doesn't. And so this clenching is actually something that's normal. Here's an example of clenching that's normal. Everyone probably has seen a weightlifter lift weights in a picture or a video or something. What are they doing with their jaw when they're lifting weights? Clenching. Why are they doing that? Everyone's seen it. Anyone question it? They're doing that because they're fixating their posture muscles. So if I'm going to go pick up something like a flower pot or a box, often I'll hold my breath in the part where I'm using my posture muscles to make myself rigid. Posture muscles in the body are stomach, back, neck, and jaw. Postural muscles are ones that are always on, otherwise things don't maintain the way they are. If your jaw didn't have some resting tone, you'd be walking around with your jaw hanging open. I don't see too many people doing that right now, so you all have some tone in your muscles, right? And so those posture muscles are a little bit harder for us to sense and feel. And on top of it, those posture muscles, we often inadvertently use all of them when we do a task, such as that physical task where you're intensely moving a weight, or when you're writing that email that you don't like, or you're focusing on a task like a fine motor skill, or like me, when I was writing the script up at night, I was clenching. Those are normal things. But again, those TMD people, that becomes a perpetuating factor. And so we work on trying for them to understand all of them. I just went through one of the perpetuating factors. So we went through education, and we were going through habit reduction. And so helping people understand how this all fits together and how their body works helps them now start paying attention, understanding, and changing behaviors. So we're in the business of changing behaviors in that aspect to be able to get people feeling better. And I want to move that into thinking about our patients in whole. We need to, as a profession, healthcare providers, dentists, physicians, physical therapists, we need to be thinking more of where do we want to start with things? How do we start moving the needle forward? Because we have a lion's share of work to do with the 35 million people that have TMD. Thankfully, we have a minority that are on the spectrum where they're refractory to care. But research would suggest that those people that are refractory, they started on the minor aspect of things. It's a progression, a chronification. So if we can get to the field where we're preventing, where we're doing education, for every epidemiological problem, the answer is always the same: education, right? Infectious disease, doctors, wash your hands. You spread a lot less infectious disease. Cover your mouth. Education to the masses is how you move the needle the most. And so with that, I want to be able to reiterate that the power to heal is within the patient. It's patient-centric. It's not within us as dentists doing things to them, fixing them. It's within them. The rehabilitative approach is effective. It is evidence-based. And self-management is the first step. And I showed you some of those data that says that it can be really effective when implementing it in a systematic way. So with that, I want to say thank you for your attention, and I'm hoping that this type of talk will get out to the masses and maybe help move the needle for a few people out there. Thank you.